What I'm going to be talking about today is what we need to know about antiretrovirals in order to not only treat a baby like this, who's a full-term baby, but one like this, who's born a little bit early and we call it a late preterm baby, and then one like this, who's a little bit earlier at 30 weeks gestation, down to a baby like this at 28 weeks who needs some intensive care intervention in order to be with us, and down to a baby like this who is in the range of our smallest baby at the lower limit of viability at 24 or 25 weeks gestation. And the first quick thing I wanted to talk about is why do we want to use antiretrovirals in these neonates? But I think because of the talk we had yesterday about early infant diagnosis and early infant treatment. For this audience, I don't need to go into this in any detail, but we want to use antiretrovirals not only in neonates for prophylaxis, but also in empiric therapy for infants at high risk of infection and for treatment for those babies who are infected. And then the other question I think comes to mind is, well, why are we worried about low birth weight babies? These are small babies. They're not a serious or significant problem. Why do we have to spend time thinking and worrying about them? And I think the reason is because there's a significant number of these babies. Low birth weight is defined as weighing less than 2,500 grams. The global prevalence is that these are about 15.5% of births, which results in about 20 million infants each year, and the vast majority of these babies are in developing countries. There's two ways babies can become low birth weight. One is to be born early, to have preterm delivery, and that's birth before 37 completed weeks of gestation, and that's estimated at 41% of low birth weight babies. And the other is to have intrauterine growth restriction and not grow up to the norms in utero. And about 59% of low birth weight infants are born at term and are small for gestational age. And these two things are not mutually exclusive. You can be premature and small for gestational age as well. In resource-rich environments, most women who are pregnant get early prenatal care, and they have a pretty good recollection of the first day of their last menstrual period, and it's very likely that they'll get an ultrasound sometime early in the pregnancy. And so we generally have a pretty good idea of the gestational age of the babies. In resource-limited settings, women often come for prenatal care much later in the pregnancy. They have a much hazier recollection of their dates. Ultrasound may not be available, and often the estimates of gestational age are much less accurate and precise. So when we do work in this area, we tend to focus on low birth weight babies as the entry criteria in the studies, because you can get a very precise measurement of birth weight. It's much harder to get a precise measurement of gestational age. And then maternal HIV infection contributes to both low birth weight and preterm delivery. There was a recent meta-analysis which looked at 52 cohort studies and found that maternal HIV infection increased the risk of low birth weight by 73% and preterm delivery by 56%. And the estimate that's commonly used is that about 20% of infants born to women living with HIV are low birth weight. Now, what do we need to know about low birth weight babies and antiretrovirals in order to use these drugs safely and effectively in this population? Well, we have to understand something about the pharmacology of these drugs. And when we talk about pharmacology in this sense, we divide it into two domains, into pharmacokinetics and pharmacodynamics. Pharmacokinetics can be summarized as what the body does to the drug. It's also referred to as drug disposition, and the with 4 domains, with absorption, distribution, metabolism, and elimination. And we need to understand what the impact of the physiology of the newborn and the premature newborn is on the pharmacokinetics of the drugs. But the other thing that's important to know about is the pharmacodynamics. And this is what the drug does to the body. And if the effects caused by the drug are what we want, or are desirable, then we call that efficacy. And if they're not desirable, at least in the clinical situation where we're using the drug, then we call it toxicity. And it's important to have an understanding of both the pharmacokinetics and the pharmacodynamics of drugs if we're going to use them safely in a population. So how is pharmacology different in neonates? Rather than go into a lot of detail on this now, I'm going to talk about it just pretty quickly in summary here. And then when I talk about the individual drugs, I'll try to focus on what the important aspects of pharmacology are. But when it comes to pharmacokinetics, with absorption, clearly there are differences in GI tract function, differences in diet, and the formulations that are available for use in neonates from older infants, children, and adults. In terms of distribution, there's change in body composition, and this is not only a change in size, but in the relative proportion of what's in the body. Premature babies have more total body water and a lot less total body fat. They're not only smaller, but their surface area, because they are smaller, their surface area is larger than their volume or their weight, and their heads are a lot bigger proportion of their body than in older people. In addition, the plasma proteins, which bind drugs in the blood and keep drugs in the central compartment, may be different. The concentrations of the plasma proteins that bind drugs, primarily albumin and acid 1-alpha glycoprotein, are lower, and they may not be as sticky in the newborn, so protein binding may be different. And so the distribution of drugs between the central compartment, between the blood and the tissues may be different as well. There are also changes in the activity of the pathways of drug metabolism and elimination. Both the enzyme systems that metabolize drugs and the elimination systems, primarily the liver and the kidney. And then what about pharmacodynamics? Well, in terms of efficacy, will the efficacy of ARVs be the same? We heard yesterday in the talk on immunology about how the immune system in children and infants is different than adults. In premature babies, it's even more different. The immune system is developing. These babies, we know, they have a high susceptibility to infection. Their immune system doesn't seem to work as well in some ways. Sometimes that's a benefit. They don't have hypersensitivity reactions. We never see allergy or those drug reactions and those types of drug reactions in the NICU. But the question is, and I don't think this has ever been looked at in an organized way, is that will the efficacy and the beneficial effects we're looking for of antiretrovirals be the same in these premature babies who have different immune systems? And then in terms of toxicities, there are unique neonatal safety issues. These babies have physiologic conditions that are different than older, more mature extrauterine organisms. So they have hyperbilirubinemia very commonly. They have anemia of prematurity. They're undergoing tremendous amounts of growth and development. If you think about a 1,000-gram baby who's born at 27 weeks and that goes home 12 weeks later, that baby will have more than doubled in size. Imagine if we doubled in size over the space of 3 months. The growth that these babies go through is tremendous. And they have specific physiology and diseases. They have surfactant deficiency syndrome causing them to have respiratory distress, and then they develop chronic lung disease as a result of the things we have to do to keep them breathing during this time. Their GI tract functions very differently, and they have feeding intolerance and then can develop necrotizing enterocolitis. Their brains are very immature, and they can have, it's very common for them to have periventricular, intraventricular hemorrhages. And so there's a whole host of specific of specific conditions that these babies have that are different than not only older infants and children, but then term infants as well. And what happens if we don't understand the pharmacology of drugs and we use them in this population? Well, I'm a neonatologist by my clinical training and my clinical practice, and it's unfortunate that in the history of neonatology we have this long path of therapeutic misadventures where we've tried to do what we thought was the right thing, and they turned out to be fairly catastrophic. So it goes back to the early 1950s when the standard treatment for newborn sepsis was penicillin and streptomycin. And this new drug came along, sulfasalazole. And they said, oh, let's give it to the babies because the drugs we are using for infection aren't working very well. So they did, and some of the low birth weight babies who were getting sulfasalazole started getting kernicterus. And it turns out that sulfasalazole displaces bilirubin from albumin, and at its therapeutic concentrations on a molar concentration, the concentration of sulfasalazole about equals the concentration of albumin. So it was displacing most of the unconjugated bilirubin off the albumin, and that unconjugated bilirubin was then free to cross the blood-brain barrier and cause kernicterus. So that was recognized that that was bad, so then they said, well, what's the next new drug to come along that we can try? And that was chloramphenicol. And I mean, most people have probably heard about gray baby syndrome. And gray baby syndrome was cardiovascular collapse in the babies who got chloramphenicol. And it happened not because there was any intrinsic reason why newborns can't tolerate chloramphenicol, but the people prescribing it didn't understand that the metabolism of chloramphenicol was much slower in newborns. Chloramphenicol is glucuronidated, and they just sort of scaled down the dosing from older children to newborns, and that was much too high a dose in the babies, and so they had very elevated levels of chloramphenicol and gray baby syndrome. This continued in the 50s, and in the late 50s they were using a lot of oxygen to treat respiratory disease and apnea in low birth weight babies, and it was discovered that a lot of these babies, because they were getting too much oxygen, were developing retinopathy, or what we call now retinopathy, and blindness. What they called then was retrolental fibroplasia, because all they saw was the end product of this, where there was this fibrous mass behind that they could see in the eye. And so there was this epidemic of RLF, and so when that became recognized, oxygen use cut down. That resulted in a tremendous decrease in the incidence of RLF, but it also led to an increase in mortality of low birth weight babies and a worsening in their neurodevelopmental outcomes. So we gained something on the one hand by not harming their eyes, but the babies there as a group suffered in having less good survival and worse outcomes in those who did survive. And then it's continued through the era where we developed the units and the techniques and the equipment and the staff to provide what we now call neonatal intensive care. When we first started doing this and putting catheters in babies, we would flush the catheters when we drew blood from them, or regularly to keep them open. Those flush solutions contained benzyl alcohol, and that resulted in metabolic acidosis, encephalopathy, and death because the dose of benzyl alcohol was too great for their livers. The babies developed chronic lung disease from the respiratory treatment we were giving them because their lungs lacked antioxidants. So people said, well, vitamin E is an important antioxidant. Let's give them vitamin E. So Eforol was an IV vitamin E formulation that was developed, and its use resulted in hepatic toxicity and death. In the 1990s, we said chronic lung disease is a disease of inflammation. We know that corticosteroids can inhibit inflammation, so we gave them large doses for 6-week courses of dexamethasone, and we thought it was great. We thought we were doing a great job because we wiped out chronic lung disease. And it was a dramatic change in the babies that we saw in the nursery. But fortunately, some long-term follow-up studies were done, and it had a very negative effect on their brains, and there was a significant increased incidence of cerebral palsy and developmental delay. And now we try to avoid use of systemic steroids in our babies if at all possible. And then more recently, there was a respiratory stimulant called doxapram. It's used in adults with COPD, and people wanted to use it. Where's Jason? Jason, this was in Canada. And they used doxapram for apnea of prematurity, and it again helped with the apnea, but in some follow-up studies it was neurotoxic and it caused developmental delay. So using drugs in the absence of an understanding of their pharmacology in low birth weight premature babies can be disastrous. So what do we know now as far as antiretrovirals go? On this slide I have all the antiretroviral drugs that have been licensed. The ones in black type are the ones where there's a formulation that we can use in term babies, and we have some safety and dosing information. You can see that we have information on a lot of the NRTIs. For the other classes, the information is much scantier. In NNRTIs, we have information on nevirapine. For the protease inhibitors, lopinavir, ritonavir, although as I'll talk about, there are some safety concerns about lopinavir, ritonavir in neonates, and nelfinavir. Nelfinavir is not widely used now, and the powder formulation that we gave to babies is not available. And when we did give it, bioavailability was very unpredictable, and about half the babies had decent exposures to nelfinavir, and the other half had almost none. And as we increased the dose, the exposures of the ones with good, the concentrations in the babies with good exposures just went higher and higher, and we still had about half the population who just didn't seem to be absorbing the drug at all. So even though we know something about it, it's not a great drug in general, and in newborns it was not very promising for use. We have no information on any of the entry or fusion inhibitors. For the integrase inhibitors, we do have not only information, but we have an FDA-approved licensure for Raltegavir in neonates. And this licensure, which was obtained last year, is the first new antiretroviral to be licensed in the neonate since emtricitabine more than 10 years before. So there was a gap of over 10 years where no antiretrovirals were licensed in the newborn. If we look at low birth weight and preterm babies, the list is even shorter. So there's some people joked with me beforehand that this is going to be a quick talk because there's not a whole lot of drugs I can talk about. But we have some information on Lumiodine. We have a lot of information on zidovudine because it's used in prophylaxis. There are a lot of low birth weight and preterm babies who were exposed to ZDV, and over 15 years ago we were able to characterize the pharmacology of ZDV along the age spectrum, as I'll show you. We have some information about nevirapine and some information about lopinavir now that has recently come forward. So the first drug I'll talk about is ZDV. As I said, ZDV was used for has been used for prophylaxis ever since the 076 study, and its use was rapidly transferred down from term babies to preterm babies. We collected some therapeutic monitoring data from preterm babies who got ZDV, as well as some data from studies, and put it together in a population PK analysis, and came up with the following, with this graph showing the increase in ZDV clearance with age. So on the y-axis here we have ZDV clearance, and on the x-axis here we have preterm, 5 minutes, okay, preterm birth here, and then postnatal here, and you can see that it's very slow in preterm babies. It goes, it's higher in term babies at birth, and then there's a very rapid increase in the first weeks of life. And on this side of the graph is some data on maturation of liver glucuronidation, and this is done from autopsy specimens on liver slices, and it was plotted with that same sort of x-axis, and that's why we plotted the ZDV this way. But again, in the premature babies, it's very low. Late in the third trimester, it starts to be an increase. This is about term, and then you have a rapid increase through the rest of, in the first 4 to 6 weeks of life. And so that resulted in, we did a study looking at a modified dosing schedule based on those data, and that's presented here. And these are contained in the U.S. pediatric guidelines, and I'll let people go there to find the details of that if they need it later. As far as Lumiodine, it's eliminated by the kidney, and its maturation of its elimination follows the maturation of renal function. And in the first month of life, it's very low, and so we use a reduced dose of Lumiodine in term babies of 2 milligrams per kilo and greater than 4 weeks. Then it goes up to 4 milligrams per kilo. There is some very limited data on preterm babies. These are babies around 34 weeks gestation. There's really just a handful of them, but if you look in the guidelines, you'll see recommendations to use this dosing down to 32 or 34 weeks, but that's really based on very little data. If we look at nevirapine, this was data on nevirapine trough concentrations in babies getting single-dose nevirapine at birth, and you can see that this is the log concentration, so 3 is about 1,000, and you can see that the concentrations go down very slowly until by day 8, all the babies, nearly all the babies are above 100, which was the target, exposure target for prophylaxis, and even out to day 14, a lot of the babies after a single dose had high concentrations. So because of this experience with preterm babies and these drugs, we developed this protocol, Impact 1106. It's a phase 4 prospective PK and safety study of ARVs and TB drugs in low birth weight babies. We're doing this study at 2 South African sites, FAMCRU in Cape Town and PHRU in Johannesburg. And between August 2015 and March of this year, we enrolled 91 infants. In order to do the study, we had to come up with a way to deal with the adverse events these babies have. Just if you think about a sick preterm baby, they may have problems with multiple organ systems. Almost every lab test you send off will come back out of the normal range for adults. And the monitoring and reporting of adverse events for a research study is very difficult. So we came up with a list of expected adverse events, and we graded them. This is what our CRF looks like. And if you can see for apnea, this is intended to be used by the neonatologist who can go and just check off boxes to evaluate the baby, and grade 1 is less than 6 spells per day. So think about a minute what this is saying. If the patient doesn't breathe, 6 times a day or less, that's grade 1 toxicity. Okay, I think in other parts of the hospital, if patients don't breathe, That's kind of a significant event. In the NICU, when patients don't breathe, a monitor may go off, and then someone goes over to the bedside and shakes the baby, and the baby starts breathing again, and we hope it gets monitored, it gets charted in the baby's record so we can keep track of how often it happens. But that's just an indication of how different the physiology of these babies are. And then we have data from the study on nevirapine and Kaletra. The nevirapine data is presented here, and the blue line is the 50th percentile, the median concentration, and these pre-dose concentrations are here at time 0. This red line is 100 nanograms per mil, or 0.1 microgram per mil, which is the prophylactic target, and the higher red line over here is the therapeutic target. And you can see that all the babies were above the prophylactic target with this dosing regimen, 2 milligrams per kilo for the first 2 weeks of life, then 4 milligrams per kilo. But if we're going to hit the treatment target of 3 micrograms per mil, we're going to have to do better and have a different dosing regimen because more than half the babies were below that target. In addition, we saw a relationship in our population modeling between age and CYP2B6 metabolism phenotype. That's shown here on the slide. I'm out of time, so I don't have time to discuss it, but this is just to make the point that some of the genetic polymorphisms that we see in drug metabolizing systems still also have an impact in preterm babies, even when their metabolism is very low. To quickly go over lopinavir-ritonavir, this is the information about the lopinavir-ritonavir toxicity that was reported with the oral solution. I just want to point out that lopinavir-ritonavir oral solution is 42% ethanol. That's like 84 proof, which is like Jim Beam or Jack Daniels. And it's 15% propylene glycol, so it's like you take your Jim Beam or Jack Daniels and spike it with a little antifreeze. And that's basically what this solution is. So it's not that surprising that some of the babies had some pretty bad toxicity. There have been some previous work done in the PK of lopinavir-ritonavir in preterm babies. There was a population PK study done by a European group reporting some therapeutic drug monitoring data that showed there was a change in elimination over time, and there was also some trough concentrations that were studied in South Africa, and so that convinced the doctors, the neonatologists in South Africa, that they could use the 375 milligrams per meter squared dose in low birth weight babies. We have data on 23 babies. 16 of them were low birth and 7 of them were normal birth weight. Their age range when they started on lopinavir-ritonavir was 33.9 to 41.9 weeks for over half of them. For 13 of the 23, that's 57%. And these are babies who are below the age of the FDA black box warning. For whom the FDA says lopinavir-ritonavir shouldn't be used. These babies were followed for toxicity very carefully. Osmolarity was measured, and they got EKGs and echocardiograms to look at toxicity, and we didn't see any problems with them. On average, the concentrations look good. So the green line is their median concentrations, and the black line is the median in adults. But you can see a lot of variability around the median. So the 50th percentile looks okay, but there's a lot of variability, and these low concentrations seem to occur in the smallest baby, and this is something we have to look into and make sure that early on we're giving an adequate dose to these babies. We have a lot more work to do in interpreting these data and do some modeling and some simulations and come up with a lot more sophisticated understanding of what we know. And then I was going to talk quickly about Raltegavir. Diana presented some data on Raltegavir yesterday, but just want to point out that the concern about Raltegavir in preterm babies is it may bounce bilirubin off albumin in a similar way to sulfazoxazole. And so we did an in vitro study, and we have here two concentrations of plasma with two concentrations of bilirubin, 10 milligrams per DL and 18, and the different Raltegavir concentrations. Fortunately, Raltegavir physiologic, the effective concentrations on a molar basis is much lower than sulfazoxazole. So at the usual Raltegavir concentrations, which is about 10 millimolars or so for a peak concentration, there was no effect on bilirubin binding, but when it got up to 500 micromolar, or 50 times the typical concentration, we started to see an effect, and at 100 times, 100-fold here, it was up in the, it bounced bilirubin off of albumin equivalent to sulfazoxazole. So Raltegavir will be okay to use in premature babies as long as the dosing is appropriate and doesn't lead to excessive concentrations. And the problem is Raltegavir is eliminated by glucuronidation, the same as bilirubin. The data that Diana presented was for babies who were starting here. And the question we have to answer is, what about the babies whose livers are working down here and are not glucuronidating very well? And so the take-home points that I want to leave you with is to use drugs safely in low birth weight preterm babies, we need to understand the developmental pharmacology of the individual drugs in this population. Currently, we have data to allow antiretroviral dosing recommendations in low birth weight preterm babies for ZDV, 3TC for babies who are over 34 weeks postmenstrual age, nevirapine for prophylactic purposes to achieve the prophylaxis concentrations, and lopinavir-ritonavir for babies who are over 34 weeks postmenstrual age. Soon we'll have data from P1106 for abacavir, 3TC, trimethoprim sulfa, and INH. And that'll provide us with a lot more information. There's a study of the safety of Raltegavir in low birth weight preterm neonates that's under development, and that will address that question of what's the right dose to use in preterm babies that will avoid excessive concentrations and put them at risk for kernicterus. We have studies in term babies of the PK and safety of Maraviroc underway and of dolutegravir under development. And once those studies are done in term babies, the next step will be to do them in preterm babies. So in conclusion, I want to leave you with where we started, with, which is with the babies, and that it's important that we understand what we need to know about these drugs in this population, so we can use these drugs safely in not only the term babies like this one, but in all of these babies, because when it comes to babies, their health and well-being is really in our hands. Thank you.